Solomon Paul and Dr. Rajesh for inviting me to give this lecture. We all know that Down syndrome has existed for more than 150 years. It still remains an incompletely understood entity. History of Down syndrome. Way back in 1866, Dr. Langdon Down defined the Down syndrome phenotype. 100 years later, Dr. Lejeune in Paris discovered trisomy 21. In 2000, the sequencing of the human chromosome 21 was accomplished, and recently, 2020, in the midst of a raging pandemic, 50 odd investigators met up at NIH, Washington, D.C., and they lay down the recommendations for future Down syndrome research, and this is a very exciting thing that has happened recently. The lifetime prevalence of Down syndrome has increased from 3.3 to 6.7 per 10,000, and life expectancy likewise has increased from 30 years in the 1980s to currently 60 years, maybe because of improved infection control and improved cardiac techniques. It is pan-ethnic. We all know about the risk factor of advanced maternal age at conception and Down syndrome. Two candidate genes, CIS2 for meiosis 1 errors and CYP2 for meiosis 2 errors, have recently been discovered. Possible environmental exposures of oral contraceptive pills, solvents, bisphenol A at work and home environment have been linked to Down syndrome, and this graph shows a slightly increased worldwide prevalence of Down syndrome, possibly due to the increased human population. This slide shows that it is multi-system involvement in Down syndrome, right from the mid-phase retrusion to sensory issues like hearing and hearing and vision impairment, recurrent respiratory infections, obstructive sleep apnea, autoimmune disorders, hematological malignancies, immune dysfunction, obesity, GI malformations, infertility in the males, hypotonia, congenital heart defects. But the most important one is the intellectual disability, language disorders, cerebellar hypoplasia, psychiatric disorders like anxiety, depression, and ADHD, autism, etc., early onset Alzheimer's, and epilepsy. Having said that, I must say the manifestations are in varying degrees in the different individuals with Down syndrome, but 5 important manifestations stand out because they are consistently present in all individuals with Down syndrome. This is intellectual disability, cerebellar hypoplasia, early onset Alzheimer's, hypotonia, and the mid-phase retrusion, causing the characteristic Down syndrome facies in all. This shows a common age-related morbidity in children and adults with Down syndrome, but this slide just tells you that all manifestations don't occur at a single time. Some occur in childhood, some in adulthood, and some like dementia come in by middle age. So we all know that Down syndrome is the most common genomic disorder causing intellectual disability. It is caused by partial or complete replication of HSA21. It's a multi-gene, multi-system, multi-pathway disorder. Meiotic non-disjunction occurs in 96% of cases. Translocation occurs in 3 to 4%. Mosaicism occurs in 1 to 2% of cases. Partial trisomy is rare, occurring in less than 1%. We know that HSA21 is not only the smallest chromosome, it is also the poorest chromosome in terms of functional DNA elements per megabase. According to the latest GenCode release, there are 233 protein coding genes, 423 non-protein coding genes, and 188 pseudogenes. It is considered a disorder of gene expression dysregulation. There are two hypotheses. One is that it could be caused by the gene dosage effect, which could be direct with downstream consequences. Example could be your APP gene triplication, of which causes early onset Alzheimer's. Developmental instability, where there is disruption of homeostasis by genome-wide effects of transcription regulation. The other players involved in molecular pathology of Down syndrome is epigenetics. There is definitely altered regional and global methylation patterns observed with the overall bias towards hypermethylation. These methylation alterations are established early in development as evidenced by multiple tissue involvement. One hypothesis is that key genes involved in methylation pathways are triplicated. This, for example, SLC1, 9A1, FTCD, GART and CBS are involved in one carbon methylation. MIS18A is involved in maintenance of centromeric heterochromatin, and DIRC1 is involved in histone acetylation and deacetylation as well as chromatin remodeling. The mitochondrial phenotype in Down syndrome is very distinct. There is reduced ATP production by oxidative phosphorylation mechanism. There is decreased respiratory capacity. The mitochondrial membrane potential is impaired, and not only functional, there are also structural alterations of the mitochondria. All this leads to increased oxidative stress, and that is believed to have an important role in intellectual disability and early onset Alzheimer's observed in Down syndrome. These are the candidate genes: NRIP1, SUMO3, DIRC1, ARCAN1, superoxide dismutase 1 gene, APP gene and CBS genes. This picture depicts, this is a chromosome 21, and the genes in red are the genes which are triplicated, which have a bearing on mitochondrial dysfunction. This is a picture of the mitochondria, where mitochondrial biogenesis leads to increased production of ATP, and ATP is important for neuronal differentiation and growth. So one hypothesis is that when these genes are triplicated, they impair this important key gene which is involved in mitochondrial biogenesis, and thereby reduce ATP production. Going on to targeted therapies against oxidative phosphorylation impairment in Down syndrome. These drugs in the blue, that is resveratrol with proglitazone, DNP, fluoxetine, which is an antidepressant, curcumin, which is our turmeric, apigenin is a flavonoid found in citrus fruits and green leafy vegetables, ketogenic diet. They upregulate this key modulator of ATP production, and EGCG downregulates DIRC1. Fish oil, which is rich in omega-3 fatty acids, targets ARCAN. Metformin, which is a well used and safety profile known anti-diabetic drug, works against NRIP1, and hemin works against BAC1. MicroRNAs are endogenous RNAs that pair with messenger RNAs of protein-coding genes to direct post-transcriptional repression. There are 29 microRNAs in human chromosome 21, overexpression of which causes haploinsufficiency of the target proteins. This has been linked to neuropathology, CHD, childhood leukemias, and lower incidence of solid tumors observed in Down syndrome individuals. This is just a picture showing the loci of microRNA in chromosome 21. We know that 802 and 15 are involved in neuropathology, and these two, that is 99A and let's say C, is involved in congenital heart defect formation. Along with mitochondrial dysfunction, the lysosomes are also impaired in Down syndrome. Lysosomes are organelles which are important for breaking down biomolecules, And in Down syndrome, both morphology and functional alterations are found, and the key pathway impaired is autophagy pathway. Mouse models, model organisms have greatly helped us gain an insight into the molecular pathophysiology of Down syndrome. These are some of the model organisms which have been used, and we see that chimp chromosome 21 is almost identical to human chromosome 21. And how do they help us to understand Down syndrome pathogenesis? When you have an observation or a question about a phenotype in human 21, trisomy 21, this hypothesis leads to a cellular and molecular level testing, and testing is done in the model organisms, and that this can then next be validated in human cells as well as trialed in clinical trials. We move on to cancer and Down syndrome. We know that Down syndrome is a cancer predisposition syndrome. There is a 10 to 30-fold increase in hematological malignancies in children. Strangely, there is protection for solid tumors except testicular cancer in adults. So, there is a 500-fold increase for acute megakaryoblast leukemia, that is M7, and transient abnormal myelopoiesis. I have seen 3 newborns during my time in Child's Trust with Down syndrome having this transient abnormal myelopoiesis, where the blood count is very high, as like leukemia. This is a transient phenomenon. It resolves by itself, but 10% of these newborns, Down syndrome newborns with DAM, can progress on to acute megakaryoblast leukemia, and GATA1 gene mutation is implicated both in DAM as well as AMKL. A good thing is that the response to low dose chemotherapy is very good. Coming to ALLs, there is 10 to 20-fold risk for Down syndrome children, and the genes incriminated are CRLF2 with the fusion genes, others like JAK2, NRAS, KRAS, RUNX1, ETS, DIRK1, etc. So this is a pictorial representation. This is the, let's say this is a hematopoietic progenitor cell. The first hit is a trisomy 21. The second hit is a GATA1 mutation. This becomes TAM, and in the bone marrow, this smolders as myelodysplastic syndrome. And when there is a third hit, it gets transformed to acute megakaryoblast leukemia. Strangely, neuroblastomas, Wilms tumor, brain tumor, which are common in normal children, are rare in Down syndrome. In adults, likewise, there is a low risk for lung cancer, breast cancer, colon cancer, with a slightly increased risk for testicular malignancy. The genes which are seen to have a protective effect are ETS2 and DSCR1, which suppresses vascular endothelial growth factor mediated angiogenesis signaling by the calcineurin pathway. Looking at the cardiac phenotype, normal children have 1% risk for congenital heart, whereas children with Downs have 50% risk, and females are more commonly affected than males. Atrioventricular septal defect is a signature defect seen consistently in all Downs, most Downs at least, followed by ventricular septal defect, atrial septal defect, and tetralogy of Fallot. AVSDs are again more common in Caucasian, whereas VSDs are common in Asian children and Brazilian children. All of them have an increased risk for pulmonary arterial hypertension, so the need for surgery before 6 months of life becomes very important. And in adults, there is a protective effect for hypertension and atherosclerotic heart disease. This is just a flow chart. The first hit is a triplication, that is trisomy 21. The gene dosage effect and on the protein coding genes incriminated are Down syndrome cell adhesion molecule, BAP2, PLAC4, collagen 6 gene, KCN6, and ARCAN1. Then non-protein coding genes are also implicated. Non-HSA2 gene like CREL1 and other microRNAs acting on other pathways can contribute to congenital heart defect. Down syndrome cell adhesion molecule, collagen 6 gene, CREL1 all cause endocardial cushion defect. KCNJ6 causes Down syndrome arrhythmogenicity. RCAN causes abnormal valvular septal formation, along with the MR, microRNAs, mitochondrial dysfunction, and lysosomal dysfunction. We all know that intellectual disability is found in all individuals with Down syndrome, and this is of varying degree. Some have it mild, some have it severe. All of them have hypotonia and a small cerebellar volume, and the cortical surface area as well as thickness is reduced. There is decreased proliferation and differentiation of neuronal progenitor cells and increased cell death. All this starts prenatally. These are some of the candidate genes which are associated with intellectual disability, along with mitochondrial, lysosomal, and microRNA involvement. Coming to Alzheimer's disease and Down syndrome, Down syndrome remains the single most common risk factor for early onset Alzheimer's. Neuropathology like neurofibrillary tangles, amyloid deficits are seen as early as 30 to 40 years of life in Down syndrome individuals. APP gene is triplicated, and reduction to a disomic state in murine models have ameliorated some features of Alzheimer's. Other genes are these. Non-HSA21 gene is ApoE4 is an important gene. Biomarker research has evidenced that A-beta peptide ratio and neuronal pentaxin 2 neurofilament light chain and plasma PET imaging studies can be used both for studying prognosis and effect of drug therapies in Alzheimer's. Immune dysfunction is definitely dysregulated in Down syndrome. We all know that they are prone for recurrent respiratory infections, including RSV, H1N1, and recently the SARS-CoV infection. Autoimmune disorders are very common in Down syndrome individuals, and we already spoke about hematological malignancies. All three systems are impaired: innate immunity, humoral response, adaptive immunity. There is less phagocytis, defective neutrophil function, CD4 cells as well as memory cells B memory cells are decreased. Then IgM, Ig2, IgG2A, they are all decreased. So genetics, epigenetic alteration, microRNA involvement, environmental factors like precocious aging, dietary habits, chronic inflammation can all, and along with an important gene called IR gene, autoimmune regulator gene, which is dysregulatedly expressed, overexpressed, and all these can have an effect on the thymus, impairing the T cell and B cell function. There is increased inflammation, chronic inflammation, and also the innate immunity impairment. So, several studies have shown that DS individuals are vulnerable to COVID-19. There's definitely increased morbidity, 10 times higher mortality, and the gene incriminated is a transmembrane protease serine 2 gene. This is located in chromosome 21. This encodes for a protease that activates SARS-CoV-2 virus spike protein to enter the cells via the ACE2 receptor. And this may make people with Down syndrome more susceptible to COVID-19 infection. So, at the cellular level, we have dysregulated immune genes, accelerated immune aging. At the system level, we have dysregulation of antibody response, innate immunity, humoral immunity, and also the TMPRSS gene causing increased COVID-related susceptibility. At the patient level, we have associated comorbidities, poor response to vaccination, medication, and social isolation all cause an increased susceptibility to COVID-19 infections. The definite risk factors for severe outcome would be age, more than 40 years, obesity, Alzheimer's disease, dementia, male sex, congenital heart. Potentially risky factors could be the GERD, seizures, obstructive sleep apnea, chronic lung disease. These have no risk, that is living conditions, ID, intellectual disability, thyroid disorders, and behavior abnormalities. Since we know that neurogenesis starts prenatally, a lot of interest has gone into prenatal therapy in mouse models. Vasoactive intestinal peptides have been used, NAP and SAL have been used, tried, maternal dietary choline supplementation, DIRT1 inhibition using epigalactocalcin galactate, algernon. Metformin is an anti-diabetic drug safe in pregnancy, which is involved in PGC1 alpha pathway has been used. Others include fluoxetine, which is an antidepressant, curcumin is our turmeric, and apigenin is a flavonoid found in citrus fruits and green leafy vegetables. These are some of the early clinical trials involving basmisanil, donepezil hydrochloride, ECGC, folic acid, memantine, inositol. They have all shown a good safety profile. Efficacy is not, however, proved, and they have been stopped with phase 2 trials. These are some of the newer trials coming up, and transcranial photobiomodulation and sleep apnea studies. Hopefully, we should get better results in future. I like to stop by saying Down syndrome research earlier has focused only on a few HSA21 genes. Continued and expanded areas of research are the need of the hour. Advances in single technologies of the genome, transcriptome, histone modifications, chromatin contacts, proteomics will definitely provide more insight on the dysregulation of gene expression in Down syndrome. Understanding molecular pathophysiology of Down syndrome phenotype is very important for developing effective treatment strategies. Thank you for your patience.